Great. Good morning. This is a great turnout. And I don't know if there was going to be a time, but Sarah, the two people standing by the doors here really put this together, and Bill. Okay, and there's others. There's others, you know. But anyway, I want to recognize that. I've been to a lot of national health care decision day events here in the Twin Cities and in other cities. And this is, I think, the best turnout of any of those events that I've ever been to. So congratulations to you guys for organizing this. You know, why do they put nails in coffins? Keep out the oncologists. This is no joke, but it's true that, you know, medicine, at least today, you know, is like a train, and it will keep going, right? We have a thing that's called the technological imperative. We have a lot of stuff that we can do, and we will do it, and that train will keep going unless you tell us you want to get off the train, right? So, you know, right? Chief Peterson will arrive. He will resuscitate you. He can transport you. You'll arrive at the ED at North Memorial. You'll be worked up at the ED, and then you'll be admitted to the ICU. I mean, that's all going to happen. It's just going to go dun, 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 unless you have one of the documents that Chief Peterson had, or you have an advanced directive. You know, so in other words, you have to. There's a presumption that you're going to get all of the technology that we've invented since 1960, unless you tell us that we don't want it. And so that's sort of what we're here to do. And I do want to just point out that I am going third for a reason. I think these guys both have pagers. Because they actually might be needed to do something. I'm not, right? There's really nobody says for Professor Pope, like, we need to interpret this statute. We need to understand why the Senate isn't confirming Judge Garland. Justice in the seat, and we need to know the answer this morning. So that's my morning. Okay, so what I want to do is, first, I want to, this is going to be a little bit more conceptual, but I think it will be a good segue into what the next session of this morning. I want to articulate two fundamental concepts, and then after that to move into the mechanics of advanced care planning. And so the first concept is autonomy, right? And autonomy, if you look at the etymology, it comes from the Greek autonomos, right? Self-control or self-determination. Right? It's your body, you're in charge of what treatment you get and of what treatment you do not get, right? Doctors may not do things to you without your consent. But let me give you an example, and this is an old example. It's from 111 years ago. In 1905, the Minnesota Supreme Court decided a case called Moore versus Williams. And the patient, and this is the St. Paul case, the patient in the case had consented to surgery on her right ear because she had some problems, consented to surgery on her right ear. But once the doctor started the procedure, he realized that, in fact, it would be better to operate on the left ear, and that's what he did. The patient sued the doctor and won. And this is a battery, right? And won, and the Minnesota Supreme Court affirmed that. And the idea here is that the doctor acted outside the scope of her consent. She had consented to the procedure only on her right ear, and the doctor did something different than what she had consented to and operated on the left ear. So basically, the point is healthcare professionals can't do things to you without your consent. I mean, so there's this idea of autonomy, self-control, self-determination. And the second concept is capacity. And capacity is the ability to understand the risks, benefits, and alternatives to the proposed healthcare at hand. And the ability to communicate a decision about that proposed health care. So the ability to understand and the ability to communicate. Now, most of us will lose capacity at some point, whether that's going to be due to dementia, some other serious illness, or from sedation in order to treat that serious illness. But we are presumed to have capacity until that presumption is rebutted. Okay, so we all have capacity until a physician determines that we don't have it, that we don't have the ability to understand and communicate the healthcare decision at hand. Okay, so you got autonomy and capacity. And two other points about capacity. First, it is a clinical determination, right? It's not something that you need a court to do or a judge to do. It's something that a physician does. It's a bedside determination. And the second point is that it's decision specific. Okay, so you might have the capacity to make some decisions, but not have the capacity to make other decisions. So, easy example, you might have the, let's say you are having, your capacity is declining, but you still might have the capacity to determine something simple like what to have for dinner, but might not have the capacity to make a more complicated decision like about a surgical intervention, because the risks, benefits, and alternatives there are more complicated to understand. And your capacity might fluctuate, right? So you might have the capacity, you might have a lucid day, you might have the capacity one day, and might not have the capacity the next day. Or you might be lucid in the mornings, but not later in the day, depending on your medical condition or your meds. So capacity is not all or nothing. There's another concept that we use in the courts, if you go down to the probate court, right, called competence, where a judge will determine whether or not you are legally competent or incompetent. That's an all or nothing determination. This is not, right? This is it's specific to the decision at hand, and you might lose capacity and you might regain it. Okay, so I just wanted to get those two concepts on the table. Move into what we're here to talk about. If you lose capacity, then you cannot control, at least at that time, contemporaneously, if you lose capacity, you cannot control what happens to you. So advanced care planning is the key way for you to exercise control now for what happens to you later when you lack capacity. And there's two ways to exercise that control. You can control to some degree, and we heard it might be limited, but to the extent possible, you can control the what and you can control the who. Okay, and I'll unpack those. But the who, right, is who's going to make decisions for you when you can't make those decisions for yourself. And the what is what interventions is it that you do or do not want. So you all have these honorary choices. I guess you all have two, right? You have two advanced directives with you right now. And there's two parts to an advanced directive in Minnesota, which basically track what I just said. There's the who and the what, right? So the who, you can appoint an agent. That's one key outcome or goal of completing an advanced directive. The person who's going to make decisions for you when you lack the capacity to make them yourselves. And then there's the second part, which is the what, which is you can leave some specific instructions. You can complete, well, you don't have to, ideally you're here, so you're going to complete at least one part of the advanced directive. You don't have to do it this morning, but you can complete just the appointment of agent part. You can complete just the instructions part. Or you can complete both, right? So either, neither, or both. And just to expand on something Dr. Greiner said, right? If you don't have an advanced directive, there are default rules that will kick into place, right? You lose control over the who and the what, right? So the state of Minnesota will basically make those decisions for you, or Dr. Greiner will make those decisions for you, right? So the who is, well, in some cases there'll be a court-appointed guardian. That's rare, but in some instances, North Memorial might, there their social worker, their attorney might go down and get a guardian appointed. Who the judge selects to be your guardian might not be the person you would have selected to be your healthcare agent. So there could be, and again, as Dr. Grant said, the default rule is to go to the next of kin. But again, that person might not be the person, you might not have a good relationship with that person, whether it's a spouse or a child or a sibling. And again, there's a risk that the person that is selected to make decisions for you is not the person you yourself would have picked to make decisions for you. This is the value of an advanced directive. So the what, well, this is the benefit of completing the other part of the form, is that person may, even if you pick the right person, that person might not know what it is that they're supposed to do. And there's a mountain, more than 25 studies in the medical literature. Surrogates are really bad at making the same decision that the patient would have made for herself. So the accuracy rate is under 60%. And if you can imagine that if it's a dual choice, A/B, right? Like, do you want a mechanical ventilator? Do you not want a mechanical ventilator? 50%, you would get 50% accuracy just from pure chance. So not barely better than pure chance on this. So the idea, basically, the takeaway here is that without advanced care planning reduces the risk of a mismatch between your preferences and wishes and the treatment that you get. So I was also asked to address a certain number of things. Since you have a pre-printed form, you don't really have to worry about this, but legally, to be valid in Minnesota, advanced directive has to be written. Obviously, you already have a form. Your name has to be on it, you're prompted for that. It has to be dated, has to be signed, and either notarized, or, doesn't have to be notarized, or be witnessed by two witnesses. And generally, the witness can't be the agent who you're appointing. They can't be a witness to their own appointment to be your agent. And the witness can't be your healthcare provider or an employee. So if you're at North Memorial, you can't get the people at North Memorial to be your witness, normally not to be your agent either. So who are you going to appoint? You have to appoint somebody over the age of 18. And again, it generally, there's a presumption that it should not be your healthcare provider or an employee of your healthcare provider, unless they're related to you. So, or if you provide a reason, a special reason why you would want to overcome that presumption. Right? Maybe they're the person who you know the best because you've been in that facility for a long time and they know you, you know them, you trust them. So it's not a bar to having your healthcare provider serve as your agent. It's just a presumption. Important, you have to make sure that they're actually willing to serve, so you fill this out. That authorizes them to make healthcare decisions on your behalf should you lose capacity. It doesn't force them to do it. If they don't want to do it, they don't have to do it. So it's a good idea to actually make sure that they're willing to do it ahead of time. And of course, to talk to them to make sure that you guys are on the same page in terms of what it is that what you would want to do for yourself, that they understand what that is so they can do it for you. Your agent has no authority at all to make healthcare decisions on your behalf until you lose capacity. So long as you have capacity, healthcare providers are going to ask you, what do you want? Or the fire department is going to ask you when they arrive, what do you want us, it's when you lose capacity that then the agent has authority. And your agent only has the authority that you give them. And so you'll see in the forms that you have, if you want to put limitations on the scope of your agent's authority, you can do that. If you want to specify a process or procedure or standard by which your agent will make a decision. So you might choose sister number 1 to be your healthcare agent, but then you might specify, well, in making the decision, I want you to consult with sister number 2, right? So you can specify a process by which they'll reach the decision. And even without any limits, any directions, the law requires that agents act consistent with your preferences and wishes. That's their duty. And I guess I should clarify one thing. We're only talking about healthcare decisions, right? So when you appoint a healthcare agent, they only have the authority and the power to make healthcare decisions for you. Nothing we're doing, none of these instruments, none of the ones in the under tables, have anything to do with making financial or property or any of those types of decisions. You need separate legal instruments to empower somebody to make those decisions on your behalf. This is only healthcare decisions. Okay, so that's the who, that's the appointment of agent part of the advanced directive. So the other part, the what. So here you can list specific treatments that you do want, specific treatments that you do not want, but perhaps that's a little bit complicated, right? Especially perhaps for this morning. More important, perhaps, is to, at a higher level, to articulate your goals and preferences, right? So I want to be able to live at home, or I want, so in other words, as opposed to getting into the gritty, do you want CPR, or do you want mechanical ventilation, do you want antibiotics? That might be a little bit too fine-grained, but the form does prompt you for your goals and preferences at a more personal level, right? What is it that you want to be able to do? The other thing, I guess, that is a little bit more easy to articulate without a conversation with your family, without as extended a conversation with your family or healthcare provider, is the where, right? And so you can specify if there's a particular long-term care facility, a particular hospice, or a particular hospital that you want to be treated at. The form also is a vehicle for you to in order to make a donation of your organs and to identify what sorts of funeral arrangements you might want. Really important. Once you complete the form, articulate who you want to be your agent, you sign it, it's witnessed, you have to make copies of it, right? Because the study, and there's a Department of Health and Human Services study, right? 75% of the advanced directives that are completed are not available. So when you're admitted to North Memorial has a duty under federal law to ask you, do you have an advanced directive? So the social worker or the admitting clerk is going to ask you. They will always ask you when you're admitted. A lot of people, well, actually not that many people say yes because the completion rate is not that great. But of the people, of the subset of people that say yes, then they say, okay, well, where is it? Well, I don't know. So they have completed it, right? But it's unavailable, which means it's just as good as if you hadn't completed it. Because if it's not available to the healthcare providers, then you might as well not have done it. So you have to make copies and give, obviously you want to give one to your agents, right? And the alternate agent, right? In case your primary agent is unavailable at the relevant time, they're on vacation or something, you normally want to have an alternate agent, right? But you want to give a copy to the agent and the alternate agent so when they arrive at North Memorial, they can prove that in fact they are authorized to be the agent. Advanced directives do not expire, so they're good indefinitely until you revoke them or until you modify them. You can revoke it just by ripping it up, you can draw a big line through it, you can burn it. This is actually in the statute. These are the ways to do it. The legislature really thought up a couple of different ways that this could happen. You could tell two witnesses. The other way, but the key way to do it is to write a new one, okay? Because later in time, let's say you did one today, which is April 16, 2016, and then you did one next year, April 16, 2017. That would constitute a revocation of today's advanced directive. So a later in time document revocates the earlier in time document. But again, remember, you better go get those old copies back because, again, the later in time advanced directive legally revocates the earlier time advanced directive, but if what arrives at the hospital is the earlier time advanced directive, that's what's going to be followed. So you have to make sure that, again, you distribute the newer one in the same way that you distribute the older one. When When should you do this updating? The best advice I ever heard is the 5 Ds. This is what the American Bar Association Commission on the Elderly recommends. The 5 Ds. Death, not your death, but the death of, obviously, the death of a family member or friend. Divorce. You might want to then, although the statute automatically presumes in that case that person's not an agent anymore, but you might want to reconsider the advance directive by divorce. 3rd, a new diagnosis, changing your clinical circumstances. 4th, a significant decline in your health care. Again, these are times where you might want to reconsider what you've written in the advance directive. And then the 5th is every decade, so at least every 10 years, you want to revisit the advance directive. And then the last 2, I was also asked to talk about reciprocity, right? So let's say you have your fellow advance directive today to Minnesota, and then you're in Wisconsin. So Minnesota law requires that Minnesota healthcare providers honor an advance directive from another state. And almost every other state has a law that requires that healthcare providers in that state honor advance directives from other states. But that's the law, and reality is sometimes different. So a Minnesota advance directive may look unfamiliar to providers in other states. Here's a good example, Florida, right? So lots of people go to Florida, maybe for the winter. So Florida legally should honor a Minnesota advance directive. But again, it looks unfamiliar, it's from out of state, and in the hospital, people might be uncomfortable with that. So the easiest thing to do is just to fill out a Florida advance directive. Ideally, you do it on the same day, so you don't have this question about the Florida advance directive was later in time and constitutes a revocation of the Minnesota advance directive. And you definitely want to make sure that they're consistent, right? Because then you create this sort of confusing situation. Yeah. So if you go on the same day, make sure you're pointing the same agents to both advance directives. And I think that's the best way to accomplish the issue of the out-of-state effectiveness of the advance directive. So I'll stop there. Thanks.
Did you want one quick question?
Yes, please.